Alright, this is lecture 26, the digestive system. This one's pretty long, so we may end up being two, we'll see. The digestive system has two categories of organs, the GI tract, those in the GI tract, and then the accessory digestive organs that assist in the process of digestion. The organs of the GI tract form a continuous tube from the oral cavity, the mouth, all the way to the anus. That includes both all the regions of the pharynx, the esophagus, and the stomach, as well as the three portions of the small intestine, and then the five of the large intestine. Within the lumen, that inner opening, food is broken down into smaller components to be absorbed. Now, something important to note here, that until food is absorbed through the GI tract wall, it doesn't technically enter, it's not technically considered inside of the body, meaning that anything that we eat, even once it's into the depths of our small and large intestines in our gut, it's still technically outside of the body because the GI tract is this continuous tube. And that's just an evolutionary principle to help us make sure that we don't ingest any pathogens, or any pathogens that we do ingest have to pass through several layers before they can actually enter into the body. So the accessory organs assist in the breakdown of food, some producing secretions that they empty into the GI tract, including your salivary glands, your liver, and your pancreas. We've already seen a lot of those. The teeth and the tongue participating in chewing and swallowing, and the gallbladder, which concentrates and stores the liver secretions at the bottom. Here it is, just broken down for you. So the six main functions of the digestive system, you have ingestion, motility, and secretion. So the introduction of nutrients into the oral cavity, this only occurs in one place. You should only ingest food through one place. Motility, both voluntary and involuntary. Motility doesn't just mean moving materials through the GI tract, it's also mixing and moving materials through the GI tract. And we'll see that this mixing plays a really big portion in actually being able to create chyme and being able to, once food has been broken down, mix it with those digestive secretions coming from the other secretive organs. So for secretion, process of producing and releasing fluid products, facilitating digestion. Those could be digestive enzymes, acid, bile, saliva. That contains several different things, lots of enzymes, or a couple enzymes rather, to help break down food. Digestion is the breakdown of ingested food into smaller structures. Starts in the oral cavity, and it pretty much continues all the way through to the small intestine. You have mechanical digestion, chewing, and mixing. So actually chewing with your mouth and your teeth, it's called mastication. That helps to also mix things up. Your tongue aids in mixing as well. And then even as you go into your stomach, it churns, and your gut churns and mixes up food. Your chemical digestion, you have your enzymes breaking chemical bonds, amylases, lipases, nucleases, proteases, those are the main ones. Absorption is the transport of digested nutrients. So the fifth function is the absorption. So actually being able to, once food has been broken down into those constituent elements and molecules, being able to absorb those into the body. Moving from the GI tract into blood or lymph. If it is a water-soluble item, then it can be moved into blood. If it is fat-soluble, then lymph will absorb it through lacteals. Those are the lymph vessels in the small intestine. The last step is elimination, expulsion of indigestible components that are not absorbed. Again, should only really happen in one place. And again, notice that these are things that are not absorbed. So by the time that something is eliminated, that obviously means that it can no longer be absorbed, right? Or it was not absorbed by the body. Hollow tube, the GI tract wall. So now looking at the different components of it, it has four concentric tunics. Tunics are the layers. We saw that in vessels. The innermost is your mucosa. Deep to that is the submucosa, then the muscularis, and the adventitia. And just to be clear here, when we say this is the innermost, this is the portion closest to the lumen. So as food is passing through the tube of the GI tract wall, it's going to be touching this mucosa layer. Okay? And we'll see the submucosa that houses the blood vessels and the nerves. This is where absorption occurs. Muscularis layer is going to help in that mixing and churning. And the adventitia and the serosa, this just refers to that outer covering of connective tissue, of tissue that's going to help connect it to the abdominal wall. So the mucosa, that innermost mucous membrane, I say mucous membrane, the epithelium is in contact with the lumen contents, allowing for secretion and absorption. Right? So that's the type of epithelium, the layer that it has, is going to allow for both of those processes. Some areas are non-keratinized stratified epithelium to withstand abrasion. In your mouth and your pharynx, they're not going to be really as prone for secretion absorption. It's going to be mostly for making sure that any abrasion or damaging substances won't tear up the epithelium too much. The lamina propria has connective tissue, blood, lymph, malt, nerve vessels. We've seen that malt is the mucosa-associated lymphatic tissue for immune functions. And absorption occurs when substances move into these vessels. Oh, I said the submucosa earlier. I meant mucosa. The lamina propria specifically of the mucosa. And it's because it has these blood and lymph vessels. The mucosa layer also has its own muscularis layer. These contractions facilitate the secretions into lumen and increase contact of material with mucosa. So they're going to help with basically releasing the juices from the secretory cells. And they do this, and I always kind of think this is kind of funny to think about. Basically, they just make the cells jiggle. So once it's time for those cells to release their secretions, this muscularis mucosa layer just kind of contracts and relaxes back and forth and just kind of jiggles the cells, and they release their stuff. So absorption. Digested substances are transported from the lumen of the GI tract through the epithelium. You have your microvilli. Those are going to contain brush border enzymes. They're going to help increase surface area for absorption. You have your epithelial cells, the basement membrane, attaching it down to this lamina propria that has actual blood and lymph vessels for absorption. Most of them are going to be absorbed into blood because they're going to be water soluble. The rest are going to be absorbed through lymphatic capillaries. Okay, deep is your submucosa. It has larger blood vessels, malt vessels, and nerves. You have your submucosal nerve plexus. We'll see that there are two nerve plexuses in the GI tract. The submucosal one has nerves and ganglia innervating smooth muscles and glands of the mucosa and submucosa. So these will specifically, remember, in case you've forgotten, a plexus is just a network of nerves. So whenever you have your brachial plexus, you have your submucosal nerve plexus, you have your enteric plexus. These are just groups of nerves that are going to be forming around one structure. Deep to the submucosa is your muscularis. It has typically just two layers, your inner circular and your outer longitudinal. We'll see that in the stomach there is an oblique layer. There's a third layer for further mixing and churning. The inner circular constricts the tube of the lumen, and the longitudinal will shorten it. Together, these will move components through. There is a myenteric nerve plexus with axons and ganglia between layers to control those contractions. So the muscularis layer has its own nerve network for controlling those contractions. The muscularis is thickened at several points to form sphincters. Those work to close off the lumen and control movement of materials into the next section of the GI tract. We'll see, or we already kind of talked about in lab a little bit, that a lot of the times the stimulus for those sphincters to open and close is the presence, or pressure rather, of food pushing up against or on one side or the other of the sphincter to allow it to open or close. The muscularis mixes and moves contents within the GI tract. The mixing lacks directional movement. It's not moving forward or backward. It's just being mixed right where it is, blending ingested materials with secretions. So, the slower, just like we had in our lungs, the slower the capillary transport is, the more gas exchange can occur. The slower that this kind of works through, to a degree, at a certain point, you do have to have motility in your GI tract. But, like when we have diarrhea and we just completely empty out our GI tract, we're not going to be absorbing any nutrients. You have to have this kind of process of ingested material being mixed with the digestive secretions, just kind of sometimes staying in one spot and just being mixed to really get digested. Propulsion is directional movement. We call that specifically peristalsis, which is sequential contraction of muscularis GI tract wall moving like a wave. It's this kind of wave of movements. So here is your mixing and your propulsion. You can see it can kind of go back and forth, and as it does, it gets further segmented until it gets broken down even more. And then you can have your circular and longitudinal muscle. They work together to push the contents through. We'll get into this a little bit more. Not right now. But essentially there are receptors ahead of the bolus and right behind it that are kind of signaling with each other too about, okay, you need to relax, now we'll contract. You relax, we'll contract. That nerve plexus. Okay, the outermost tunic, the adventitia or the serosa, it just depends on the organ location. So the adventitia is made of areolar connective tissue holding the organs together. Same with the serosa. They work to reduce friction between the gastrointestinal organs. The serosa is completely covered by the visceral peritoneum, which would be layer covering the organs itself. And this is only for intraperitoneal organs. If it's retroperitoneal, then it's the adventitia. And we'll just see, remember your peritoneum is your abdominal cavity. It can be intra or retroperitoneal, meaning it's behind it. There is just, again, another breakdown of those tunics. Your mucosa with its three constituent layers. The submucosa, it has the nerve plexus. The muscularis with its 2 layers of muscle, as well as its own nerve plexus, and then the serosa or adventitia. Okay, regulation of the digestive system. So you have learned all about the nervous system. We mentioned briefly, I'm pretty sure that we go over briefly in chapter 16, the enteric nervous system. This is the one that essentially is going to be innervating the smooth muscles and glands of the GI tract, coordinating mixing and propulsion reflexes. It has both sensory and motor neurons within those 2 plexuses. The autonomic nervous system also plays a role in this. So this is kind of the digestive system's internal regulation. It's kind of locally regulating itself. There is kind of overarching overall regulation by the autonomic nervous system. Parasympathetic promoting, sympathetic opposing. Okay, so parasympathetic, remember, is your rest and digest. It's going to help to aid in secretions and mixing and send more blood there for absorption. You have different reflexes. You have baroreceptors detecting the stretch in the GI tract wall. Remember, I said that the bolus will kind of stretch in certain parts, and that will send signals for other parts of the GI tract to respond. Chemoreceptors monitor the chemical contents of lumen. Is it fatty? Is it an acid? What kind of components are here? What kind of secretions do we need to break this down? The reflexes, either the autonomic or the enteric, are initiated in response to receptor input. You have short reflexes, which are local, only involving the ENS, and coordinate small segments of the GI tract. So the enteric nervous system isn't going to kind of connect your stomach to your anus, which is, it's going to be kind of regulating portions, just small sections of the large intestine, of the small intestine, movement maybe in the stomach a little bit. It's not going to be regulating the overall process. Those would be your long reflexes. Sensory input to the central nervous system and autonomic motor output, coordinating GI tract motility, secretions, and accessory digestive organs as well. Remember, the ENS is only with the muscularis and submucosal nerve plexus. Plexuses? I still don't know, sorry. Hormonal control, several hormones participate in regulation: gastrin, secretin, cholecystokinin, motilin. We'll learn them. So looking at the serous membranes of the abdominal cavity. The peritoneum is a serous membrane associated with the abdominopelvic cavity. You have the parietal peritoneum lining the inside surface of the abdominal wall. So remember, the parietal actually lines the cavity. The visceral is going to be covering the organ surfaces. The peritoneal cavity is the potential space between these 2 layers. Lubricating serous fluid secreted from both layers allows abdominal organs to move freely and kind of shift freely. We saw that with the serous fluid in the pleural cavity. Intraperitoneal organs are completely surrounded by the visceral peritoneum, your stomach, most of the small intestines, and parts of your large intestine. But there are parts of the GI tract that are not going to be covered by the visceral peritoneum. They are going to be retroperitoneal, lying directly against the posterior abdominal wall. Only small portions covered with peritoneum. That is going to be most of your duodenum, so that first portion of the small intestine, the pancreas, the ascending and descending colon, and the rectum. So it's just sections of it that are retroperitoneal. You also have a mesentery, which is a double layer of the peritoneum, supporting, suspending, and stabilizing intraperitoneal GI tract organs. It has blood and lymph vessels, nerves, all sandwiched between the folds. One of those layers is called the greater omentum, covering most of the abdominal organs. It accumulates large amounts of adipose tissue, so it's called the fatty apron. If you've seen some images of the GI tract, it's like you can see the organs, but they're kind of under this yellowy, kind of lacy kind of thing. That is the greater omentum. It's your fatty apron. There's also the lesser omentum, the falciform ligament in the liver, the mesentery proper, and the mesocolon. There's arguments that the mesentery should be treated as its own organ, just because it has all the different tissue types, so it has multiple types of tissue, so it can technically be classified as an organ, but also for just the multiple roles that it plays in supporting and protecting the GI tract and the intraperitoneal organs. So here's that greater omentum. In it's kind of just hanging, covering. Yeah, you've got the falciform ligament and the liver right up here. The lesser omentum right in there attaching. You can see the mesentery proper for the small intestine holding it together. All right, so now we're going to start getting into the actual GI tract organs. There is a packet, a small packet. It's like a little foldable thing. It will be on Blackboard. It has all the different organs. It has the entire GI tract laid out. I recommend that you download this, print it out, and fill it out. So you can see like mine, I have like in each one, just little notes about the organs, about each of the structures to help me keep things organized, to make for a quick review. And I think on the back of one of these, yeah. And then on the back of mine, I talk about hormonal control and then the nervous control, as well as the 4 tunics. So these 3 pages are pretty much all of my notes for the digestive system. There is an answer key to this. I will post it not in the beginning of the week, I will post it later in the week. So that way you will actually have a chance to make it yourself. I highly encourage that. If all you do is just write down what's on the answer key, you're not going to learn anything, because it also has probably a lot of information you don't need to know. Maybe you don't need to be, reminded that, let's see what's something here, that the oral cavity is a site of ingestion. Maybe you don't need to be reminded that, but it could help. Okay, so oral cavity and salivary glands. Mechanical digestion begins here. Saliva is secreted from the salivary glands in response to food. That contains salivary amylase, enzyme initiating digestion of starches. It gets mixed with ingested material to form a bolus. So once the food gets chewed up and masticated, it gets mixed with salivary secretions, it becomes a bolus. In the pharynx, the bolus is moved to the pharynx during swallowing. Mucus secreted to facilitate that swallowing, just to help lubricate it. It moves then into your esophagus. The bolus transported from the pharynx, transports the bolus from the pharynx to the stomach. The upper third of the esophagus is skeletal muscle, and the lower third is smooth. We'll see that there are voluntary and involuntary portions to swallowing, but this skeletal muscle is still involuntary. It's skeletal, so that way it can kind of go in one direction, and then the lower third, that being smooth, will kind of just make sure it goes the best way into the stomach. In the stomach, the bolus is mixed with gastric secretions by smooth muscle contractions. Remember, you have the 3 smooth muscle layers of the muscularis layers of the GI tract wall here. The secretions produced by epithelial cells of the stomach, and that bolus mixing with the secretions from the stomach are going to turn it into chyme. Duodenum, the duodenum is that first portion of the small intestine, and it is also considered part of the upper GI tract. So now getting more specific. The oral cavity is your mouth. It is the entrance to the GI tract. There are 2 distinct regions, the vestibule and the oral cavity proper. The vestibule, if I remember correctly, is that space between your teeth and your gums, and the oral cavity is the entire thing. Obviously, I'm not going to get too specific about that. The uvula is the conical projection for the posterior soft palate. It elevates with the soft palate during swallowing to make sure that nothing goes up into the nasopharynx. Your tongue is primarily skeletal muscle with both extrinsic and intrinsic muscles. Numerous projections called papillae are involved with taste, your taste buds. The tongue helps to manipulate and mix materials during chewing, as well as function in swallowing and speech. You don't really kind of notice how important your tongue is for eating until you really start to focus on it, and you notice how much you manipulate food with your tongue. And then when we go to swallow, again, we'll get into this, but our tongue really helps to push food up into those ridges at the hard palate, the front, the anterior portion of the oral cavity, and then helps to push back. There is your whole oral cavity. We've seen that several times. Your salivary glands produce saliva. You have both intrinsic and extrinsic salivary glands. These are intrinsic, obviously, within the oral cavity, continuously releasing secretions independent of food. These contain lingual lipase, which is an enzyme that will be in digestion but isn't activated until the stomach. The extrinsic salivary glands are outside of the oral cavity. These are the ones that we've known and studied, the parotid, submandibular, and sublingual. These produce most saliva. So the parotid salivary glands are your largest ones on the side of your head. They produce 25 to 30% of saliva. These submandibular salivary glands produce 60 to 70, and then the sublingual only 3 to 5%. There are two types of secretory cells within salivary glands, both mucus cells, which produce mucin. It forms mucus upon hydration, and serous cells, which produce this watery fluid that has electrolytes and salivary amylase. The proportion varies between the different glands, between the parotid, submandibular, and sublingual. So even though they secrete different amounts of saliva, they also are going to have different different proportions of these glands. So saliva, spit, right? It isn't just that watery fluid. We make about 1 to 1.5 liters secreted daily. Remember, for urine, the obligate urine production is half a liter. So you produce as much saliva as you do urine, and if you are properly hydrated, it's a lot of saliva. Most of it being produced during mealtime. It is 99.5% water and a mixture of solutes, including salivary amylase, mucin, and lysozymes for immune functions. The functions of saliva are to moisten ingested food. Salivary amylase initiates chemical breakdown of starches, dissolve food molecules, stimulate taste receptors. It helps to cleanse the oral cavity, and it has antibacterial substances, both lysozymes and mucus IgA antibodies. For taste receptors to be stimulated, they do need to, the food molecules have to be kind of broken down and exposed, and they need to be moist, they need to be wet, otherwise the taste receptors won't respond as well. Same thing with a dog's nose. If a dog's nose is dry, it can still smell, it's fine, but it doesn't conduct that chemical, or it doesn't stimulate the receptor quite as effectively if the dog's nose is dry versus if they're wet. Don't wet your dog's nose though. Regulation of salivary secretions by salivary nuclei within the brainstem. You have a basal level of salivation, which is done by parasympathetic stimulation. That just kind of basal is just like the most basic, most kind of baseline of secretion level that you need. The receptors detect stimuli, particularly acids in the oral cavity and the stomach. They send signals to salivary nuclei in the brainstem. The signals also come from higher brain centers in response to just the thought of food. So it's that idea of like, you see a commercial and all of a sudden your mouth just starts watering. It's thinking about food really does produce that. Increased parasympathetic output to salivary glands is going to increase those secretions. Sympathetic stimulation results in a more viscous saliva. And this one just kind of goes back to like the basic function of the sympathetic nervous system is to retain water. So when our sympathetic nervous system is activated, it is going to reduce the amount of watery fluid produced by those serous glands. There's those broken down. You can see that these have ducts. That makes them an exocrine gland, not an endocrine. Here is just kind of a representation of that. So you have these mucus cells. Notice how these are also called alveolus, so just like a bulging of cells, right? And then there's a mix of serous cells too. All right, mechanical digestion, your mastication, your chewing, increases surface area to facilitate exposure to digestive enzymes. If you just swallow something whole, corn is a wonderful example. If you don't really take your time to chew up corn, it does not get digested as well. It will promote salivation and controlled by nuclei in medulla and pons within your mastication center. Lots of things happen there. You have 20 deciduous teeth erupting between 6 and 30 months, eventually replaced by 32 permanent teeth. You have your incisors for slicing, canines for puncturing and tearing, premolars for crushing and grinding. The gums are your gingivae. They're overlying non-keratinized, stratified squamous epithelium, very much helping to protect those underlying structures. Yeah. I always tell people I have 24 teeth because I had braces, so they pulled a lot of my adult teeth, plus the wisdom teeth get taken out. So I only have 24. So it's always fun. Count your teeth. See how many you're supposed to have 32. How many do you actually have? Most of us are going to have at least 28 because we almost all get our wisdom teeth taken out. Oh, we already did that. Molars for grinding and crushing. There's your gingiva again. I'm not sure why they keep coming back up. Okay, this is the largest pair of salivary glands, which produce mostly watery saliva. Yes, your parotid glands. Big key there, if you can't remember which ones produce the most watery saliva, the largest pair, right? They are by far the largest. This layer of the digestive tract is in direct contact with the food that is consumed. That is going to be, correct, your mucosa. These muscular contractions move material through the digestive tract. If we're moving material, that is called peristalsis. Deglutition is swallowing. There's your teeth. Permanent teeth. Okay, notice how little time I'm spending here, how I'm not even mentioning the ages that they erupt. That should be a clue to you. Okay, now moving into the esophagus, the pharynx and esophagus. Normally the esophagus is collapsed. It's a tubular passageway. It only opens when there's food in it. The trachea has those cartilage rings that keep it open. This begins at the level of the cricoid cartilage, directly anterior to the vertebral bodies, posterior to the trachea. So sandwiched in between your trachea and your, let's see if I can do this on one side, your trachea right here, and then your vertebrae right here, you have your esophagus. Inferior region connecting to the stomach. It passes through an opening in the diaphragm called your esophageal hiatus. A hiatus is just a hole, a space that something can flow through. The last 1.5 centimeters is in your abdomen. We'll see that when someone has, you can get what we call a hiatal hernia, which is where portions of this esophagus, this abdominal esophagus and stomach will actually go back up through this hole, this esophageal hiatus hole. So I don't think we have a clinical slide on any of this, so I'm going to go ahead and take a minute to talk about it. Essentially, when you eat, you swallow something and that expands your esophagus, which is going to stretch this esophageal hiatus. If you then immediately go and lay down, all of your organs are going to start to shift back up, and this esophageal hiatus is going to be a little distended because you've been eating, you've been swallowing, and let's say you were really hungry. Thanksgiving is always the classic example that we use because you're stuffing your face, you're eating a lot, and then you go lay down. Then you go relax. And so you've eaten this big meal, it's stretched out that esophageal hiatus, now you lay down, and that those organs will start to shift back up, and portions of the organs, the esophagus and the stomach, can get caught up above this esophageal hiatus, and then as you rest, that esophageal hiatus will start to close off, and it will trap a portion of it above the diaphragm. And eventually it can cause a lot of pain and have to be surgically repaired, I should say. Okay, your superior esophageal sphincter is a contracted circular ring of skeletal muscle at the superior end. It's the area where the esophagus and the pharynx meet, closed during inhalation of air. Your inferior esophageal sphincter is at the inferior end where the stomach where it meets the stomach. It's not strong enough to stop by itself to stop stomach contents from regurgitating, so the diaphragm muscles help. Remember, it is below that last part is below the diaphragm, right in there. This is also called your cardiac sphincter, your lower esophageal sphincter, and I think there's your gastroesophageal sphincter or something. So be prepared for multiple names with that one. The esophagus has non-keratinized stratified squamous epithelium. Just to give you a quick refresher, non-keratinized, so your skin is keratinized, meaning that it's dead. Right, it's all been replaced with keratin. So if it's non-keratinized, that means that it's still living tissue. You know that your oral cavity is very much living tissue. It repairs itself very quickly. Stratified because it's layered. It's not just one thin layer. It's got multiple layers to it. And squamous just refers to that shape. It's got that kind of flat, like eggy kind of. I think that's what they always describe it as. It's like an egg kind of shape. Just very much just flat though. So that is going to be very much giving it a protective quality. You have a submucosa with abundant elastic fibers that permits distension during swallowing, as well as numerous glands providing lubricating mucus. The muscularis has both skeletal and smooth muscle. 2 layers of skeletal muscle in the superior third are skeletal, ensuring material moves rapidly out of the pharynx. Intermingled in the 1/3, and smooth muscle only in the inferior 1/3. So you have kind of this mixture. And it's all skeletal, and then, or rather, it's kind of like right here. It's all skeletal, and then it's going to be a mix, and then it's going to be just smooth. The process of swallowing is deglutition, moving ingested materials from the oral cavity into the stomach, and this occurs via 3 phases. The first is the voluntary phase, occurring after ingestion, so you put something into your mouth and you chew it, and then you decide, okay, it's time to swallow. This is controlled by your cerebral cortex. You start to use your tongue, you push food back, and then you go into the pharyngeal phase. And we kind of know there is that point when you're swallowing. Please don't try this, okay? There is that point when you're kind of going to swallow where it's like, oh, I could stop, but then there's that no return where it's like, nope, I gotta stop now and just hope that it goes the right way. That's your pharyngeal phase. It initiates this involuntary reflex. Sensory input goes to your swallowing center and the medulla oblongata. And those signals get relayed to effectors. That's going to cause elevation of the soft palate and the uvula to block anything going up into the oral pharynx. Nerve signals sent to the medulla oblongata to ensure that breath isn't taken, because remember, the medulla oblongata also has the respiratory center. And it moves the epiglottis to cover the laryngeal opening. Then you go into your esophageal phase. This is again an involuntary phase when the bolus passes through the esophagus. The bolus stimulates sequential waves of muscular contraction, propelling it towards the stomach. It's basically stimulating baroreceptors that push it in the right direction. The superior and inferior esophageal sphincters are closed at rest, and then they relax when the bolus starts to swallow, contracting again, preventing reflux of materials. This is a great little image. You should know all these phases. Definitely knowing which ones are voluntary and involuntary. And I'm trying to think if there's anything else. Just kind of the regulation with the medulla, especially regulating breath with swallowing. All right, reflux esophagitis and gastroesophageal reflux disease. Inflammation of the esophagus due to acidic chyme refluxing into the esophagus. Remember, chyme is from the stomach. The stomach has a very low pH that can go back up if the lower esophageal sphincter isn't closing properly. You get pain posterior to your sternum, heartburn, so that kind of just burning, stinging. If you're under 25, you probably haven't felt it. Just wait, it's coming. It's seen most frequently in overweight individuals, smokers, and after large meals. Hiatal hernias, like we talked about, the portion of the stomach protruding through the diaphragm. Treatment are lifestyle changes, head elevation, and limiting meal size. One of the biggest things that I've seen with people that I've talked to that have had this issue is just not laying down right after eating, just making sure that, yeah, you're kind of limiting your meal size and that you're actually keeping yourself propped up slightly. You're not reclining too quickly after meals. This can result from chronic esophagitis. It starts to erode esophageal tissue. Scar tissue builds up, leading to narrow lumen. So this is talking about refluxing too much acid into the esophagus. It can eventually start to change from stratified squamous to columnar secretory epithelium, which is known as Barrett esophagus, increasing the risk of cancerous growth. May be treated with multiple medications, including the proton pump inhibitors and histamine blockers. So it's basically just kind of saying that this is a very classic sign of cancer, is that you start to switch the type of epithelial tissue that it's producing. That can rapidly lead to improper replication. All right, now that we're in the stomach, we can start talking about chemical and mechanical digestion. Continuing here, notice that when we were in the pharynx and the esophagus, we did not mention any kind of digestion. There's none happening. Digestion of proteins and fat begins in the stomach. Your ingested materials spend about 2 to 6 hours here, and absorption becomes limited to small nonpolar substances. Serves as a holding bag for controlled release of partially digested material. So this time can depend both on how much it is that you're eating, when was the last time that you had a meal, and if you're trying to eat again. All of those things can affect the movement of things out of the stomach, rather. Very, very limited kind of absorption stuff, small and nonpolar only. And it holds. That's kind of, it is very important for chemical and mechanical digestion and mixing things up, but it's also this holding bag for controlled release, so that way the small and large intestines can really have their time to work through material. There are 4 regions in the stomach. You have the cardia, which is the superior entryway into the stomach lumen from the esophagus. Once food enters the cardia, it goes and shifts over to the fundus. Then it moves down to the body, which is the largest region, and then the final region is the pylorus. This is a funnel-shaped pouch forming the terminal region. It has a ring of circular muscle called the pyloric sphincter that regulates entry of material into the duodenum. There are also what we call rugae, these gastric folds that are on the internal stomach lining when it's empty, and they allow the stomach to greatly expand when it fills with food, then return back to normal. So as the stomach expands and gets fully distended, these will start to disappear and go away, and then they'll come back once the stomach reforms. Yeah, that's just kind of the general overview of the stomach. You've seen this if you did your lab already. You have your 3 layers of the muscularis, the outer longitudinal, the middle circular, and then this deep oblique layer. And unlike the detrusor muscle of the bladder, which also has kind of a mix of different muscle layers, these are distinct layers. The detrusor muscle does not have the distinct layers. It has different directions, but they're kind of crossing all over each other, whereas this is very much 3 distinct layers. So the stomach is lined by simple columnar epithelium supported by a lamina propria, has a very abrupt transition from the esophagus, assuming that the esophagus has not been converted. Lining indented by depressions called gastric pits. Inside of the pits are gastric glands. These extend deep into the mucosa, partially surrounded by muscularis mucosae, helping to expel the gastric secretions. Remember, that's the one that kind of shakes and wiggles them. On the muscularis, the stomach varies from the general GI tract pattern. You have the 3 smooth muscle layers and not the 2. That 3rd layer assisting in the churning and blending. And it thickens as well as it goes from the body to the pylorus. So that muscularis layer is actually going to get thicker. It also has the serosa is going to be its visceral peritoneum. Okay. There's just a breakdown of it. We're going to get into these gastric glands right here. So 5 different cells. You have your surface mucus cells that secrete alkaline fluid containing mucin. That is going to basically help protect all of these cells. So your stomach, the inside of the stomach has a very low pH. It's usually about 2 to 3. But actually in the pits and in where the gastric glands are, the pH is 7. The pH is very neutral. And it's neutralized because you have these surface mucus cells that secrete this layer of mucus that kind of covers the actual epithelium of the stomach to make sure that they aren't eroded away by the acid. When you have stomach ulcers from the H. pylori bacteria, what they're doing is they're burrowing through and creating holes in this mucosal layer that allows the stomach acid to then reach the epithelium and literally burn a hole in your stomach. Okay, gastric secretions are produced by the 5 secretory cells. 4 of them produce gastric juice, and the 5th type secretes a hormone. The first ones, the surface mucus cells, line the stomach lumen and extend into the gastric pits, continuously secrete alkaline product containing mucin, preventing ulceration of the stomach lining, and it prevents gastric enzymes protects gastric enzymes from high acidity. The mucus neck cells are immediately deep to the base of the gastric pit. I'm not so concerned with their relative location in the gastric pit. What I think is much more important is what is their name, what are they producing? These produce acidic mucin, maintaining those acidic conditions. And both types of mucus cells help protect the stomach lining from abrasion and injury. So those are the basic things that I want you to know. What are they producing? What is its function? Parietal cells add 2 substances to the stomach. One is an intrinsic factor. This is required for vitamin B12 absorption in the ileum. So it is planning ahead. The ileum is the last portion of the small intestine, but already here in the stomach, we're secreting this B12. B12 is necessary for the production of normal erythrocytes. There's also hydrochloric acid forming from HNCl, hydrogen and chloride, secreted across the cell surface, responsible for the low pH of the stomach. HCl functions help break down plant cell walls and animal connective tissue, denaturing proteins, facilitating chemical digestion. It converts inactive enzymes, the pepsinogen, into active pepsin, that is going to be digesting proteins. And it kills most microorganisms entering the stomach. Had an itch. So those are the basic HCl functions. This is, again, one of the reasons why any kind of esophageal reflux can be really damaging because you have that HCl impairing it. I don't think I really need you to know necessarily the formation of HCl, but what is important is the chloride shift. Remember, you're using chloride to transport bicarb. That's a fairly important function of chloride. And the general those functions of HCl itself. But as far as knowing these exact steps, I won't get too specific into that. Next cells, your chief cells. Most numerous secretory cells within the gastric glands. They produce and secrete pepsinogen, which is that active precursor of pepsin, becomes activated by the HCl. It must be in the active form to prevent destruction of chief cell proteins. Otherwise, if it was just active, if it was just in an active form as it is, then it would just denature the proteins of the stomach. But instead, by making sure that it's only activated when it's in a very acidic environment, and making sure that usually happens in the presence of food. Typically, we're not secreting a whole lot of things if there's no food in our stomach. If there's no food in our stomach and we are secreting things like pepsinogen and it becomes active and turns into pepsin, it could potentially start digesting our stomach proteins or be passing to our small intestine and start digesting proteins there. So having these things released only when there's food in the stomach makes sure that the stomach itself and the GI tract itself are not being attacked and digested. Because, sorry if you hold a superior view of humans, but, when it comes down to a cellular level, we get digested just as easily as any kind of animal protein that you're eating. So our body will go right for us. Pepsinogen activated by the hydrochloric acid and other active pepsin molecules, chemically digested nitric proteins into oligopeptides. It produces gastric lipase, playing a limited role in fat digestion as well. About 10 to 15% of ingested fats are going to be digested by the gastric lipase. Lastly are the G cells. These are enteroendocrine cells, widely distributed in the gastric glands, secreting gastrin hormone that stimulates stomach secretions and motility. So this is going to increase digestion and increase the activities of the stomach. It's going to increase all the other stomach secretions, all the other cells secreting things, and increase movement of food through the stomach. Yes, here you can see your G cells releasing gastrin into the bloodstream. That is going to then act on the stomach itself. Your chief cells secreting their pepsinogen in its inactive form. Mucus cells and surface mucus neck cells and mucus neck cells and surface mucus cells secreting mucin, acidic, and alkaline mucin. And then you can see this kind of mucus layer that is going to extend and protect the cells. All right, gastric mixing. Form of mechanical digestion, gastric mixing is. It changes semi-digested bolus into chyme, I should say, chewed and mixed, leading to reduction in size of swallowed particles. Churned and mixed. Gastric emptying, then, is movement of acidic chyme from the stomach into the duodenum. That pyloric sphincter will open with entrance of small volume of chyme. The sphincter closes with retropulsion, which is the reverse flow of some contents back towards the stomach. So essentially, once chyme gets into the pylorus, it's under fairly high pressure, and so it's going to push up against the pyloric sphincter, and that will open a little bit, and it will let a small amount out, and then it's going to close, and it closes so strongly that the fluid contents of the chyme in the stomach is actually going to push back on itself and kind of like a wave kind of mix back in with itself even more and increase mixing. Yeah, you can see how here this pyloric sphincter closes and then allows the chyme to mix even more in the pylorus. Regulation of the digestive processes in the stomach. So we'll see that there are the GI tract has to coordinate with itself. Your brain, your stomach, and your intestines, your rectum, your anus, all have to be working, because you can't have a backup kind of down the system and then still be allowing food to come through. Your stomach may need to hold food longer. Your small intestines may need to slow down their motility until you empty the lower portions of your GI tract. That's just kind of how it works. So the stomach is a holding bag for partially digested food until the food is moved into the small intestines, where digestion is completed. You have pacemaker cells in the stomach spontaneously depolarizing, establishing a basic rhythm of muscular contraction. Those signals spread through the smooth muscle layers into your muscularis layer. The forced contraction and the gland secretion is regulated by nervous reflexes and hormones. There are three phases: your cephalic, your gastric, and your intestinal phase, that are going to send signals regulating these processes. The cephalic phase involves your cephalic reflex, which is just the thought of food. Seeing food, thinking about food, those kind of things will initiate your cephalic phase. Nerve signals from the higher regions of the brain are sent to the hypothalamus, that then send signals down to your medulla oblongata, increasing vagal stimulation of the stomach, causing increase in motility and secretory activity, making your stomach growl, those kind of things. The gastric phase then is the process following the bolus reaching the stomach. So the cephalic phase, you haven't even eaten yet. You might not even have food in front of you, but you're just thinking about it and it's already starting. Then once you have actually gotten your food, you have chewed and swallowed it, that bolus then enters your stomach and your gastric phase begins. It's regulated via gastric reflex through the release of gastrin hormone. That reflex is initiated as baroreceptors detect the stomach stretching. There are also chemoreceptors detecting proteins and increased pH. Because unless you're drinking like Coca-Cola, it's probably not going to be the same pH as your stomach. It's probably going to be a more neutral pH. Nerve signals are again related to the medulla oblongata, increased stomach motility and secretory activity. Right. The reason for this one, it's so the gastric phase, cephalic phase, gastric phase, increased stomach activity, because your body doesn't know how much you're going to eat. It knows that you're hungry and that you may want to eat something, and maybe you have started eating, but it doesn't know, oh, is this just a little snack to kind of tide us over, or are we eating for winter here? So our body kind of initiates this process just to go ahead and get things moving. Presence of food in the stomach causes the release of gastrin that enters the blood, circulates back to the stomach, and further stimulates contractile activity and HCl release. It's not necessarily acting on the same cells though, so this is a full endocrine hormone because it is going fully into the bloodstream. I would not call it necessarily, it wouldn't be an autocrine because it's not going back to the same cell. You could probably call it a paracrine though. Also stimulates contraction of the pyloric sphincter to slow stomach emptying. That just allows and makes sure that food can be mixed and broken down properly. Then you get your intestinal phase. This is the process following chyme reaching the small intestine. So now it has moved from the stomach into the duodenum. It involves your intestinal reflex, opposing cephalic and gastric reflexes. The chyme in the duodenum initiates signals to the medulla oblongata, causing a decrease in motility and secretory activity of the stomach. You also have cholecystokinin, CCK, perfectly fine abbreviation for you to use, and secretin that decrease stomach motility and secretory activity, slows emptying of the stomach. Let's see, do I want to say anything else about this? This is basically just, as something enters into the stomach, into the small intestine to stretch, the baroreceptors and the chemoreceptors are going to send signals to the medulla oblongata, and it wants to slow the stomach because while the stomach, might be kind of initiating and getting ready to digest a whole lot of material, the intestine is also kind of thinking about, okay, well, we have to take what we have now, we have to break it down even further, we have to start absorbing things, then it has to go to the large intestine. If we haven't heard back from them yet, we don't know if they're ready yet or not, and so the intestinal reflex just kind of slows the stomach reflex down, because by decreasing all the stomach secretions and motility, it's going to make the stomach take longer. So instead of being 2 hours, it may now be 4 hours that it acts at holding back from the 2 to 6 hours that the stomach normally holds food. Those are just those processes. You should understand absolutely which ones are going to increase stomach activity and which ones decrease the stomach activity, but also the stimuli and the receptors that are going to be checking it. It's easy though; they all are going to be interpreted in the or integrated rather in the medulla oblongata. Gastric bypass. A small part of the stomach is sectioned off and attached to the lower part of the small intestine. You end up with less nutrients absorbed. It reduces your appetite, alters your response to hormones like insulin, and can induce remission of type 2 diabetes within a few days of surgery. So it's got pluses and minuses. It's a major surgery though. Peptic ulcers, solitary erosion of the portion of the stomach or duodenum. What I was going to say. Gastric ulcers in your stomach and duodenal ulcers in the duodenum. Symptoms of gnawing, burning pain in the epigastric region, nausea, vomiting, usually vomiting with blood when it gets really severe. May erode and cause perforation, which can become a medical emergency. That means that it's actually caused a full hole to emerge and there's leaking into your abdominal cavities. Helicobacter pylori causes the erosion of the gastric lining. Treatment is similar to those of gastric reflux. There's a lot of research into ulcers. You can learn a lot about Helicobacter pylori. It's one of those bacteria that I think that most of the population has, but not everybody has an activated form where it's actually causing erosion of their gastric lining. Vomiting is the rapid expulsion of gastric contents through the oral cavity, called emesis. You could take antiemetics to limit your vomiting. It's controlled by the vomiting. Real side story, because I worked in a vet's office. We had someone bring in their dog, and they were freaking out because the dog had eaten a lot of their marijuana. And generally, your response when a dog has eaten something that they're not supposed to is to cause it to vomit. The trouble is the dog had eaten a lot of marijuana, and marijuana is an antiemetic itself. And so we were kind of stuck in this situation of, well, let's just see what happens. Luckily, the dog was fine, no issues. It was okay, just tired and hungry, like you would expect. But it was just one of those things like, well, we cannot make this dog vomit, so we're going to just go with it, right? All right, little side stories. Controlled by vomiting center, surprise in the medulla oblongata. Think about, just when you're vomiting, how you have to control both your breathing and your esophagus, like that, everything, all those regulations that happen up around your neck with vomiting. So your medulla oblongata has to play a role. Responses to head injury, motion sickness, infection, toxicity, food irritation, closure of nasal passages in the glottis, skeletal muscles contract, increasing intragastric pressure. The contents forced into and through the esophagus, causing a danger of aspiration where it actually goes back down into the lungs, especially if someone is unconscious, if they are intoxicated and vomiting because they are sick. Definitely make sure that they're on their side, because if they're just laying on their back, then it can flow right back down into their trachea. Lower GI tract organs, process of digestion and absorption continues. Elimination of indigestible and unabsorbable material. The small intestine is divided into 3 continuous regions, your duodenum, jejunum, and ileum. Duodenum is still part of the upper GI tract, but we're going to talk about it here in the lower GI tract. Receiving chyme from the stomach mixed with accessory organ secretions. Most chemical digestion and absorption happens here in the small intestine. That is its main role. You also have more accessory organs, secretions from the bile and pancreatic juices, bile from the liver, stored and released by the gallbladder, pancreatic juices with digestive enzymes from the pancreas. Large intestine is primarily absorbing water, electrolytes, and some vitamins. It also produces feces that eliminates through the anus. The absorption of water compacts chyme into feces. Here they are, just arranged. You've got your stomach that's going to be sitting right here. They took it out because we're talking about lower GI tract organs and the accessory ones. Okay, let me have a sip. Your small intestine. It's your small bowel, long tube inferior to the stomach, and located medially in the abdominal cavity. So right in the middle of the abdominal cavity. By the way, just kind of when you're looking, so like here's my belly button right here. Your stomach is going to be kind of right about here, and then you're going to have your small intestines, and your large intestines are going to surround. But it goes down deep. Your intestines, like when people think about like their intestines, they sometimes kind of hold them up here, but it's lower down. It's kind of right behind your umbilicus. The ingestion nutrients reside in the small intestine at least 12 hours. That's how long they really need to be able to absorb most nutrients and fully break things down and absorb them. As well as a large percent of water, electrolytes, and vitamins. So even though we said the large intestine does this as well, the small intestine does it first, and the large intestine just kind of takes the rest. It is a coiled, thin-walled tube going from the pylorus to the cecum of the large intestine. It has its first segment being the duodenum, originating the pyloric sphincter, receiving chyme, as well as the accessory gland secretions from the liver, the gallbladder, and the pancreas. Real quick, just because I know we talked about how the liver produces bile and it gets stored in the gallbladder, but remember that when our liver can also secrete bile directly into the small intestine, it can bypass the gallbladder, and you can also have both of them secreting bile into the small intestine. The jejunum is the middle region of the small intestine, primary region for chemical digestion and nutrient absorption. The ileum is the last region. It also forms 3/5 of the small intestine. Its distal end terminates at the ileocecal valve, and it continues absorption of digested material. Inside of your intestine on the mucosa are these internal folds of the mucosa and submucosa tunics. They increase surface area to increase nutrient absorption, and they also slow the movement of chyme by acting as speed bumps. They're more numerous in the duodenum and the jejunum, and then less in the ileum. And these are macroscopic. These are not microscopic, kind of the microvilli. These are, or even villi. These are actual folds that you can see if you ever, yeah, here we go. You can actually see these folds and ridges. So they're going to increase the surface area, and they're going to kind of slow the movement of chyme. Also on the mucosa, you have villi. These are the finger-like projections of the mucosa, larger and most numerous in the jejunum. That's your primary site of absorption. It increases the surface area, contains an arteriole, a capillary network, and a venule, as well as a lacteal. So all of these are basically going to be allowing it to, the capillary network, providing it some type of gas exchange, arteriole bringing the fresh oxygenated blood, the venule draining any kind of waste, as well as ingested materials, or absorbed materials rather, will be absorbed by the venule. And then your lacteal is in there as well, responsible for lipids and lipid-soluble vitamins. So here is a circular fold. These are 3 circular folds. On each circular fold, you can see the villi, or the villus, rather, is one of those. And then we'll see that on the villi, they actually have microvilli, so they have even more surface area increasing. Here. These are extensions of the plasma membrane of the simple columnar epithelial cells, increasing the surface area of the small intestine. So when we're talking about the villi, we're talking about extensions of the mucosa. When we're talking about the microvilli, we're talking about the plasma membrane of those epithelial cells. They form what's called this microscopic brush border and have brush border enzymes to complete chemical digestion of most nutrients. Proteins for transport of digestion are also embedded here because these are on the plasma membrane. So when things are absorbed, they're absorbed into individual cells and then transported into those vessels in the villi to be absorbed into the body. So yeah, you have to have transport proteins for that. So in the small intestine, you have intestinal glands that are invaginations of the mucosa between intestinal villi, secreting intestinal juice. There are goblet cells that produce mucin, which of course gets hydrated to form mucus. They increase in number from the duodenum to the ileum. Think about that. As you go from the duodenum to the ileum, you're losing water. Water is being absorbed. So you need something to help keep the lubrication so movement can still occur, so the chyme can still be moving. And that's going to be mucin. Mucus, really. There are unicellular glands that synthesize enteropeptidase, enteroendocrine cells that release hormones like CCK and secretin, and submucosal glands that produce an alkaline mucus protecting the duodenum. Because remember that chyme is going to be very, very acidic. So one of the things that we need to do very quickly is get it back up to a neutral pH because the duodenum is not prepared for that. There's just a nice little breakdown of that. Yeah. Okay. The smooth muscle of the small intestine mixes chyme with the gland secretions. Does that with segmentation, that backward and forward motion, moving chyme against new areas of the brush border, propelling contents through the small intestine by peristalsis. Segmentation is prevalent early in the intestinal phase. It mixes chyme, accessory gland secretions, and intestinal juice. And when it talks about here about the intestinal phase, it just means as the intestinal phase of digestion, not really anything to do with the stomach regulatory phases. So segmentation prevalent early in the intestinal phase in the duodenum. Contractions initiated by the pacemaker cells and spread through the muscularis via gap junctions. Peristalsis becomes late in the intestinal phase, initiated by motillin from the duodenum. You have successive waves of contraction. You're migrating motility complexes. These essentially clear contents from the food. So peristalsis happening late in the intestinal phase, so kind of more towards the jejunum and especially the ileum. It's just kind of about moving food. By the time food has gotten through the jejunum, a lot of the absorption has occurred. So it's like, okay, now let's start to kind of move through. It's probably getting on 10, 12 hours, and so we need to get food to the large intestine now. So peristalsis is going to happen a lot later than that. Or later in the intestinal phase. These migrating motility complexes, MMCs, are housekeeping complexes. Let me make sure. Yeah. So if you have been, let's say you had your lunch, you're not planning to have dinner until 6 or 7 o'clock. You know, you had lunch at 12:30 or 1. Dinner's going to be in several hours. After you have had a meal and that has started kind of digesting, and your body realizes that, you know, again, that cephalic phase isn't happening. You're not thinking about food. You're kind of focused on something else. You have several hours where you're not, your digestive system isn't being active. These migrating motility complexes are going to be activated to help clear out your intestines and make sure that there's no kind of any chyme or food material, an undigested material getting left behind. So you sometimes kind of, when you're just like sitting, you're like, I'm not hungry. I don't know why my stomach is all of a sudden just, or my, you know, it's not your stomach, rather, it's your intestines, just kind of making those like really like, those kind of, you know, really intense gurgling sounds called Berber gastris. Sorry, Berber gastris are the stomach noises and the intestinal noises. Those really loud ones are your migrating motility complexes. You're like, I'm not hungry. I don't want to eat. I haven't eaten anything in a while. It's because your intestine is clearing itself out to make room for what is coming. Your gastroileal reflex, initiated by the ileum, it causes the ileum to contract. The ileocecal sphincter relaxes. The CCK helps to cause this, and the cecum relaxes, so that contents can move from the ileum into the cecum in response to food in the stomach. The ileocecal valve contracts then to prevent backflow. So this is by contracting, the ileum is going to increase pressure on its side, and that in conjunction with CCK will help the ileocecal sphincter to open. Content can move through into the cecum, and then it can close again, so that way there's no backflow. Okay, getting into the accessory digestive organs and ducts now. We're kind of taking a detour here. So your biliary apparatus, sorry, there's something outside my window that's like, it's like a storm happening, and so I think a tree branch fly. The biliary apparatus, it's a network of ducts draining left and right lobules of the liver. They include the left and right hepatic ducts that merge to form the common hepatic duct. That merges with the cystic duct to form the common bile duct. We did this all through lab, so I'm not going to spend a whole lot of time. You have the hepatopancreatic ampulla, which is going to be where the common bile duct and main pancreatic duct go into the duodenal wall, and the sphincter that surrounds the ampulla. There's just a nice little organization of that. All right, your liver is the accessory digestive organ and largest internal organ. It produces bile as its main function. It has your porta hepatis, where the blood, lymph vessels, bile ducts, nerves enter and leave the liver. So while your kidneys and your lungs had a hilum, this has a porta hepatis. You also have your hepatic portal vein. There's just a gross anatomy picture of it. You've seen these if you have been paying attention in lab. The connective tissue capsule branches throughout the liver organ, dividing it, forming septa that partitions the liver into those lobules. The structural and functional units of the liver contain hepatocytes, liver cells. Hepato is liver. The portal triad is at the periphery of each lobule. So on the outside of each lobule, you have the hepatic bile duct, branch of the hepatic portal vein, and an artery. So the hepatic bile ductule is going to be flowing in the opposite direction of the portal vein and the artery. These two, the artery and the portal vein, are going to be delivering things to the liver. The portal vein is going to have blood from the intestines. The artery is going to have oxygen-rich blood, nutrient-rich blood. Well, the portal vein will have nutrients in it too. Those are going to be going in towards the center of the liver, while the bile duct will be draining back out, collecting bile as it goes. At the center of each lobule, you have the central vein, which drains blood from it. It passes from the portal triads through hepatic sinusoids to the central vein, merging to form hepatic veins, which empties into the inferior vena cava. So the hepatic artery is a branch of your celiac trunk off your abdominal aorta, carries oxygenated blood to the liver. The portal vein carries deoxygenated, nutrient-rich blood from the capillary beds of the GI tract, spleen, and pancreas. It brings about 75% of the blood to the liver, so 75% of the blood flow coming to the liver comes from the portal vein. Blood mixes as it passes through hepatic globules, and the hepatic veins empty again into the inferior vena cava. So the hepatic portal vein brings 75% of blood to the liver. At any point, 25% of your blood is flowing through your liver, though. So your liver is processing a lot of your body's general blood supply at any time. As blood is transported through the hepatic sinusoids, nutrients and oxygen are absorbed, they enter into the hepatocytes. And then the stellate cells, I'm from East North Carolina, y'all. Stellate cells are macrophages that clear harmful substances. So they're actually kind of just immune cells that are making sure there's no pathogens in this blood that's being absorbed from the intestines. Bile is secreted by the liver, contains water, bicarb, bile salts and pigments, cholesterol, lecithin, and mucin. Bile salts and lecithin are going to help to mechanically digest lipids. So here are the actual lobules. So again, the liver, you can kind of take these segments and you can kind of segment it out. Liver is a really cool thing. You can lose 85% of your liver function before it actually starts before its functions become impaired, before it actually starts to really lose function. So you can lose 85% of the functional cells and portions of your liver before it really, really gets impacted, which just goes to show you how much of a kind of barrier, how important of an organ it is. It is also the only organ that can regenerate itself. You can donate, when you donate your liver, you just donate part of it, and then they put that in somebody else. It will grow in them, and yours will grow back. So you can see each of these lobules. Here are the central veins right in the middle, and then on the periphery are the portal triads. We have the artery, the portal vein, and then the bile ductal. Let's see. So yeah, this is just kind of showing the flow of fluids. So again, from the artery and the portal vein going in towards the central vein, and then going back out is the bile duct. There's just some more histology if you want to see that. You can see how large the portal vein is compared to, like, let's see. Yeah, there's the artery right there. You can probably see it. Hopefully you can see it better on your slides. The portal system, again, you have from your intestines, from your small and large intestines, these mesenteric veins coming back in to join the portal vein of the liver, so that way they can deliver all of their nutrients and have that blood checked for any kind of pathogens before it goes to the vena cava, back to the heart, gets oxygenated in the lungs, and then gets delivered to the body where all of those nutrients can be reused. All right, cirrhosis of the liver. The hepatocytes become replaced by fibrous scar tissue. This is going to compress blood vessels and causes hepatic portal hypertension. So essentially the blood pressure inside of your liver will skyrocket. Compresses bile ducts, caused by chronic injury to hepatocytes, chronic alcoholism, liver disease, drugs, or toxins. Most frequently viral infections of hepatitis B or C. Symptoms are fatigue, weight loss, nausea, pain in the upper right quadrant where your liver is. If it becomes advanced, you get jaundice, edema, ascites, which is specifically swelling kind of around the stomach or over the abdomen, itching, toxin accumulation, and dilated veins of the esophagus. Do I want to say something here? The drugs and toxins thing. This is why it's so important. One of the reasons that when you're taking ibuprofen or you're taking medicines, that you're also watching your alcohol intake. Partly because taking medicines, things like antibiotics, can make you more susceptible to alcohol, and so you can actually get drunk faster. But it's also talking about what drugs are processed by your livers, which ones are processed by your kidneys, and if your liver is having to work overtime to process not just drugs, but also prescribed drugs, but also recreational drugs, then it's going to just make it work even harder. And some things, when individually the liver might be able to handle, but when it has to handle them together, that could overwhelm it for sure. Okay, accessory digestive organs and ducts. Your gallbladder. I don't know why I keep reading these. I always want to read the top slide. So we did the liver, now the gallbladder just underneath it. The gallbladder is a sac-like organ attached to the inferior surface of the liver, storing, concentrating, and releasing bile that the liver produces. It's connected to the common bile duct by the cystic duct, and it has a sphincter valve that controls the flow of bile into and out of the gallbladder. So if you remember, we talked about in the lab how the liver can produce bile directly to the small intestine, or it can store it back up into the gallbladder. So it just has this kind of valve that will regulate and divert bile as it needs. Gallstones in the gallbladder or biliary apparatus. Unfortunately, just being a female puts you more at risk. Weight, age, and race. Condensations of cholesterol or calcium and bile salts. So basically, you just have these kind of when it says condensations, that might be kind of weird to think about, but it's basically just like a gathering, like a collection and a concentration of these things. Majority are asymptomatic until they get lodged in the neck of the cystic duct. The gallbladder becomes inflamed. You get cholecystitis. Severe pain in the right hypochondriac region. Nausea, vomiting, indigestion, bloating, and symptoms worse after a fatty meal because the gallbladder is trying to release bile, but it can't get out. May require surgical removal, called a cholecystectomy. They do it through your belly button. They go in laparoscopically and they pull it right back out. Your pancreas has endocrine functions of insulin and glucagon for blood sugar regulation and exocrine functions making pancreatic juice. The acinar cells produce and release digestive enzymes. They are organized into lobules. They have small ducts leading into the larger duct of the duodenum, that main pancreatic duct. There are simple cuboidal cells that are secreting alkaline bicarbonate fluid. That's part of your pancreatic juice. The pancreatic juice is from acinar cells and pancreatic duct cells. It has alkaline fluid, mostly water, bicarb, and digestive enzymes. We've gone over these: amylase, lipase, inactive proteases, and nucleases. You should know the state that they're released in. So are these going to be active or inactive when they're released? You should know what they're digesting. Yeah, that's pretty much what it is. Pancreatic cancer are cancer cells of the pancreatic cells, typically exocrine cells. The prognosis is good with early detection, but it's difficult because there's no screening test, absence of signs and symptoms in the early stages of the disease. Later stages include abdominal pain, jaundice, loss of appetite, and weight loss. And it's often fatal because it's usually detected late. I had a friend 2 years ago who died of pancreatic cancer. She was 42 years old. She had been to see me. I'm a massage therapist, and one of our other friends is a physical therapist, and so she had been to see both of us to try and get treatment because she was having just awful low back pain in her vertebrae, and we'd worked on her, couldn't do anything. Finally, she went to a doctor, which people, massage therapists and physical therapists will always tell you to go to a doctor, get an x-ray, see what's going on, especially when you're talking about your spine. People never want to do it, and she finally did, and the doctor was able to confirm, did a blood test, and was able to confirm that she had stage 4 pancreatic cancer, and about 8 months later, she died. It really is very fatal because it's just so hard to catch. This is what Alex Trebek has as well. He is still fighting it, thankfully. Okay, cholecystokinin. CCK is a hormone released from the small intestine in response to fatty chyme. So when you eat something, if again you're eating that, I'm trying to pick things that aren't just meat. I'm trying to think of something that's really fatty, that's like a vegetable, and I'm sure there's like a very obvious avocado, obviously. Avocado is nice and fat, so it's going to be releasing that chyme. CCK will be released in response to that. It stimulates the gallbladder to strongly contract and release. This is the actions of CCK, by the way. CCK will stimulate the gallbladder to contract, stimulates the pancreas to release pancreatic juices. It relaxes smooth muscle within the hepatopancreatic ampulla to allow that bile and pancreatic juice to actually be emptied into the duodenum. And it inhibits stomach motility and the release of gastric secretions. So CCK will slow down the gastric secretions in the gastric phase. Another one coming from the small intestine, your secretin. It is released from the small intestines in response to increased chyme acidity. So CCK is for fat content. Secretin is because of acidity and pH. It causes the release of alkaline solution containing bicarb from the liver and ducts of the pancreas. It helps to neutralize acidic chyme, inhibiting gastric secretions and motility. So CCK and secretin, two different stimuli, but fairly similar actions. Secretin maybe not as wide-ranging, but still fairly similar. Okay, now going into the large intestine. Large intestine is a relatively wide tube, shorter than the small intestine. It absorbs water and electrolytes from the remaining digested material. And water, the watery chyme becomes compacted into feces. It will store that until it eliminates through defecation. The first portion is your cecum from the ileocecal valve to the, really it's just like a little pouch. It receives chyme entering from the ileum. The appendix, the vermiform appendix is its full name, is an interperitoneal thin sac projecting inferiorly from the posteromedial cecum. So we should see a picture of it in the next slide or two. It may harbor beneficial bacteria. There was this long things about, the appendix is a vestigial structure, it doesn't do anything for us. They started taking everybody's appendixes out, and they kind of realized, you might be actually more susceptible to infectious pathogens, or to pathogens, because you don't have your appendix, because they found that there really are actually beneficial bacteria still in there. Essentially what happens is that chyme will go, as it goes from the ileum into the cecum, instead of going up the ascending colon, some of it will get trapped and go into this little appendix and get stuck in there. The colon is the second part of the large intestine. It has 4 segments, so remember we talked about this in lab. A lot of people will use colon and large intestine interchangeably, and it's not the same. Your colon is part of your large intestine. It forms an inverted U-shaped arch, making up the ascending, transverse, descending, and sigmoid colon. The rectum is the third major region of your large intestine. It is a retroperitoneal structure connecting to the sigmoid colon, a muscular tube that expands to store feces, and it has thick transverse folds called your rectal valves that are regulating movement. Here you go. So you can see here's your ileum. Chyme comes in through the ileocecal valve. There's your cecum, and then your appendix is right there, so we can just kind of get stuck right in the appendix. Chyme will then travel up the ascending, across the transverse, down the descending, and then you have your sigmoid colon before it gets stored into the rectum. Your anal canal are the last few centimeters of large intestine. You have the longitudinal columns, the depressions between, which are the sinuses. These release mucus when pressure is exerted. The internal, mucus obviously to help with movement. The internal anal sphincter is involuntary smooth muscle. The external is voluntary skeletal muscle that is normally closed off but relaxed during defecation. We looked at that in lab. Here you can see this internal sphincter surrounded by your external one, as well as some veins and valves. Not totally, never mind. Appendicitis, mostly due to fecal matter obstructing the appendix. The appendix swells, blood supply is compromised, and bacteria become overgrown. It can burst if it is untreated, causing dangerous infections and peritonitis. Pain initially referred to your 10th thoracic vertebrae around the umbilicus from smooth muscle. It eventually involves the peritoneum, pain becoming localized in the right lower quadrant. Nausea, vomiting, abdominal tenderness, and fever surgically removed through an appendectomy. The mucosa of the large intestine is lined by that simple columnar epithelium with lots of goblet cells for mucus secretion and very little intestinal villi. The numerous intestinal glands extend inward towards the muscularis mucosae, secreting mucin to lubricate the undigested material. Lots of lymphatic nodules. There you can see, fairly straightforward. Next slide. Okay, your bacteria erection in the large intestine. You have a whole lot of bacteria. Anytime you're on a prolonged, intense antibiotic regimen, your doctor will most likely prescribe you some type of replacement antibacterial, bacterial replacements to help restore, I'm trying to think, like Fluorastor is what they call it, I think, is one of the name brands. Fluorastor to help repopulate your intestinal bacteria. It's called your indigenous microbiota. Normal bacterial flora in the large intestine, breaking down carbs, proteins, and lipids in your chyme, producing carbon dioxide, hydrogen, and other substances, mostly including vitamins B and vitamin K, which absorb from the large intestines into the blood. This indigenous microbiota, they are crucial to our function, not just with the physical health, but also they've been shown to play a role in our mental functioning as well, and proper mental health. When you lose your indigenous microbiota, you can become severely immune compromised. That has to be compensated for. Let's see, did they talk about? I think we talk about fecal transplants in this lecture as well. I probably should have checked. But essentially, what will happen is if it's severe enough, if you lose enough of your bacteria. Maybe you're just kind of going on back-to-back regimens of antibiotics or something, and you kind of clear out of your bacteria. They'll typically look for people that are very close to you, either someone living in your home or someone that you spend quite a lot of time with and has similar exposure to you, because presumably they'll have similar bacteria to what you would have, and they will take a fecal sample from them, mix it up, put a tube down your esophagus, and basically just deposit fecal matter into you, which can then be reabsorbed into, which can absorb your bacteria. Your body can absorb those bacteria. It's pretty fun. Pretty interesting, right? Feces becomes your final product. Water, salts, epithelial cells, bacteria, and undigested material. Okay, motility and regulation in the large intestine. Peristalsis is weak and sluggish here. You have what's called haustral churning. The relaxed haustrum will fill with material. So remember, the haustra are those sacs of the large intestine. The haustra will relax, fill with material. This tension stimulates the reflex contractions in the muscularis layer, increasing churning and moving material to more distal haustra. Mass movements also occur. These are powerful contractions involving the tinea cauda, which is that tendon that wraps around the large intestine, the outer wall. It propels fecal matter towards the rectum. Happens 2 to 3 times a day, often after a meal. Your gastrocolic reflex, initiated by stomach distension. So as soon as you start to eat something, again, that kind of sends a signal to your colon, in this case, your large intestine, but specifically your part of your colon, that it needs to start moving things along. Gastrocolic, right? The defecation reflex. Filling of the rectum initiates the urge to defecate, sends signals to your spinal cord, increasing parasympathetic output to the sigmoid colon and the rectum, and decreasing output to the involuntary anal sphincter. Voluntary defecation is learned at about age 3, involving the Valsalva maneuver, which is where you close, your epiglottis closes over your larynx, and you bear down to increase abdominal pressure. It involves relaxation of the external of your voluntary anal sphincter. Do I want to say anything else? Not yet. There you can see graphic representation of it. This is just an extra little slide that I always like to include. If you are ever experiencing abnormal stool colors, you can talk about the potential cause. My favorite thing, though, is that almost all of them say consult a doctor. It doesn't matter what color it is. It's brown. It's a normal color. Consult a doctor. If you are confused, go for it. Black is a very bad color. A lot of times people think like, oh, there's red. So maybe they're red. There's lots of things that is typically indicating blood. If you're looking at your stool and you can see that it's bright red, that means that the blood hasn't had time to coagulate. So potentially whatever is happening is somewhere lower in your GI tract. If it is black or dark, that means that it is happening up. Especially if it's from bleeding. If these are coming from bleeding. If it's black or if it's maroon, it's a dark color. That means that it's had time to coagulate, and so it's higher up and can be even more severe. They're all severe. If you're bleeding, that's bad. But just that's why it can go from black to maroon to red and all be blood. Green, diet high in green vegetables. Consult a doctor. Yellow can be from the pancreas, celiac disease, cystic fibrosis, giardia infection. That's a bacterial infection will also come with extreme diarrhea. Had a friend who thought he had giardia. Luckily, we have another friend who's a microbiologist who confirmed him that he did not have giardia. Okay, fluid entering and exiting the GI tract. Entering should be almost equal to absorbed, except for a small amount that gets excreted. So almost all the water that enters our GI tracts, it's about 9 liters, I think. Almost 98% will be reabsorbed. Right, colorectal cancer, second most common type of cancer in the United States. It's a malignant growth anywhere along the large intestine and the rectum, arising from polyps, which are outgrowths on the colon mucosa. Low fiber diets, insoluble fiber will help to move material along through the intestine. If the longer that fecal matter sits, the more likely you are to develop cancer. History, genetics are a component, age, and history of ulcerative colitis. Symptoms could be rectal bleeding, abdominal pain, and weight loss. They must be removed surgically. They can be screened with fecal occult blood tests, sigmoidoscopy, colonoscopies. They also make. I have several friends that are older in their 50s and 60s that swear by the boxes that you can just go, you defecate in them, you send the box off, and they can. It's supposed to be 98% effective, I think. So for their minds, they don't have any other risk factors. They don't have any other symptoms that are showing. It's just a monitoring thing. So that's how they do it. Because a colonoscopy is it's a very intense process. You get knocked out for it. Here's the fecal transplant. Low cost, low risk procedure to treat Clostridium difficile colitis, fecal matter from the donor placed in the colon of the patient, either through an enema, colonoscopy, also not down through the nose and throat. That's nice. Can help treat Crohn's disease, ulcerative colitis, irritable bowel syndrome, diverticulosis, and diverticulitis. So diverticulosis is the condition of having small bulges. Diverticulitis is an inflammation of them. So you can have diverticulosis and it not be active. It just means that you have these small bulges called diverticuli, formed when the colon narrows in response to low fiber. So whenever I teach this course, people always tell me that the people in my life are I must have so many sick people in my life. But really, as you go into healthcare stuff, people just start telling you all about their things. My stepdad has diverticulosis. It is one of those. It itself is not life-threatening. Diverticulitis is. Diverticulitis is an inflammation of the diverticula. They can rupture and leak into the abdominal cavity. My stepdad's had to be hospitalized a couple of times for it. It used to be thought that things would get caught in these diverticula. So if you were eating sesame seeds or if you were eating broccoli, the little florets in the heads would get stuck in the diverticula and cause them to become even more inflamed. It's a great way to make sure that people that already aren't eating enough fiber don't eat broccoli. But that's not the case anymore. They've realized that's really, it doesn't have anything to do with specifically what you're eating. It is just it's an inflammatory condition that can come up with other factors. Constipation and diarrhea, kind of a spectrum here. Temporary impaired ability to defecate, compacted feces becomes difficult to eliminate. From low fiber, dehydration, lack of exercise, poor bowel habits, anesthesia can also cause it. Diarrhea, disruption in normal mechanism to absorb intestinal water from osmotically active solutes that move large volumes of water into the colon. So essentially, it's just saying that you have this imbalance that is just causing water to flow right through and not be absorbed into the body properly. With that, you will decrease your nutrient absorption. All right, these lymphatic capillaries are found in the villi of the small intestine. Yep, like teals. Parish patches are the mulch. The crypts of Lieberkuhn, I'm not great with actual things named after people. I'm guessing that's probably part of the large intestine. And microvilli, we've seen those. This is one of the major functions of bile salts. Very good. Emulsify fats to fatty droplets. We'll look at that. Okay. Now I'm actually getting into macromolecule digestion. So let me get a sip of water. You have monosaccharides, disaccharides, and polysaccharides. Starch is broken down into individual glucose molecules. So this is one of those things where I talk about, chapter 27 is nutrition, so we'll probably get into it again, but it doesn't really matter necessarily what you eat. Everything is going to get broken down into its most basic components. So if you aren't eating a well-rounded diet, if all you kind of eat are Twinkies, it's going to break it down into glucose, and your body will use that glucose to make ATP. It may not be able to do any other repair because you're not giving it any other nutrients or minerals that it also needs for proper functioning. But as long as it's giving some kind of starch source, it's going to make it into glucose, and you're going to have energy to go. Disaccharides broken into individual monosaccharides. Main digestion sites are the oral cavity and the small intestine. In the oral cavity, it's catalyzed by salivary amylase from the salivary glands. It breaks bonds between glucose molecules within the starch. It becomes inactivated by the low pH of the stomach. That inactivation occurs within 15 to 20 minutes. So after you swallow it, about 15 to 20 minutes later, salivary amylase is inactive and no new carbohydrate enzymes in the stomach. In the small intestine, you have pancreatic amylase, which is synthesized and released from the pancreas. It continues the digestion of starch, makes shorter strands of glucose, maltose, and individual glucose molecules. So this is just kind of showing that general process. We'll see this for each of these macromolecules. The pancreatic amylase breaks them down into smaller starch chains. And then you have brush border enzymes that complete that breakdown into individual molecules of glucose. So remember we said the brush border enzymes from the microvilli on the villi are going to further that breakdown. Brush border enzymes complete that starch breakdown, include dextranase, glucoamylase, that break the bond between glucose subunits of oligosaccharides. Maltase breaks the bonds between two glucose molecules. Digestion of other disaccharides requires one enzyme each, named for the substrate that digests. Lactase digests lactose, glucose, digests lactose, yeah. Maltase digests maltose, sucrose, all those things. I think, yeah, here's this. I don't get super specific into, okay, if you start, you can break maltose as just chains of glucose, and if you have sucrose, you can break sucrose down into glucose and fructose. I'm not really concerned with that. That you know what the monosaccharide components are of the disaccharides. I want you to be able to identify kind of the structures of carbohydrates. So polysaccharides are the most complex. Then you have disaccharides, and then you have monosaccharides. I want you to be able to identify which ones are poly, di, and mono. So starches and glycogens are polysaccharides. Your maltose, sucrose, and lactose are your disaccharides. And then your glucose, fructose, and galactose are going to be your monosaccharides. You should know the enzymes that digest each of these. So maltase, maltose, sucrase, sucrose, fructase, lactose, lactase, and amylase digesting your starches. So you should understand that basicness, but again, not having to know glucose and fructose make sucrose. That's okay. Monosaccharides are absorbed across the intestinal epithelial lining and into the blood. Venous transport it to the liver, where fructose and galactose are converted into glucose. Glucose is taken up for energy, converted to glycogen, or converted into fat. Cellulose, the carbohydrate component of a plant cell wall, we do not have the enzymes to digest that, so it gets added to the bulk content in our lumen, so kind of helping to move that kind of fibery bulkness, moving stuff along. Celiac disease, gluten-sensitive enteropathy. It's an autoimmune disorder affecting 1% of the population. Gluten is a protein in wheat and in breads, essentially, and grains. So if you think about like cake. Cake doesn't have a lot of gluten because it's kind of soft, it's crumbly. You don't want cake to be chewy. But like bread you want to be very chewy. Bread has a lot of gluten because it's stretchy. They both have gluten. Bread has more, cake has less. They're kind of on a spectrum. It stimulates an immune response, damages the villi of small intestine, and interferes with absorption. Symptoms are abdominal pain, diarrhea, and nutrient deficiencies. You have to go get tested for it. Some people are just gluten sensitive. Some people are fully gluten intolerant. Proteins are polymers composed of amino acid subunits linked by peptide bonds. The digestion releases those individual amino acids. It gets broken down by different enzymes, targeting peptide bonds between amino acids, released as inactive enzymes that must then become activated to prevent the proteins in the cell, breaking down cells in the protein. Prevents enzymes from breaking down proteins in the cells that produce the enzymes. It begins in the stomach with the lumen, stomach with pepsin formed from pepsinogen. The stomach's low pH due to HCl from the parietal cells activates pepsinogen to pepsin, denatures proteins to facilitate the chemical breakdown. Further into the small intestine, there are 3 enzymes released from the pancreas that continue protein digestion: trypsinogen, chymotrypsinogen, and procarboxypeptidase. All of them released in their inactive form, as well as enteropeptidase released in the small intestine, which activates trypsinogen into trypsin. So here is a cascade of things that are going to happen. So trypsin activates more trypsinogen to trypsin. So enteropeptidase starts by activating trypsinogen trypsin. That will then activate more. Trypsin will activate chymotrypsinogen to chymotrypsin, and it activates procarboxypeptidase to carboxypeptidase. So it activates all three of these, kind of acts like a cascade to do that. Trypsin and chymotrypsin break bonds between specific amino acids, producing smaller strands. And carboxypeptidase breaks bonds between amino acids on the carboxyl end and the remaining protein. So it kind of breaks them even further there. Essentially, you have to have all, proteins are very complex. They have an amine end, they have a carboxyl group, they have this R functional group that, could be who knows how big. And so, by the way, amine end, carboxyl, R group. Peptide bond, amine, carboxyl, R group. There could be another peptide bond here connecting it to another amino acid. So each of these has to be broken off. But what you have to have multiple enzymes to do that, because they're each going to cleave at a specific spot. They're each going to break these proteins down in a specific spot, and so it's important to have multiple types of enzymes for that. Your dipeptidase, y'all thought we were done. Your dipeptidase breaks the final bond between those two amino acids, and aminopeptidase generates free amino acids. Those can be absorbed across the small intestine, used as building blocks for new proteins, or converted into glucose. You can pretty much convert anything into glucose. Our body can do that. Here is just a nice little representation of that. I don't need you to know specifically that dipeptidase breaks the final bonds between two amino acids. I don't need you to know specifically that carboxypeptidase breaks the carboxyl end, but that's pretty obvious. What I do want you to know is be able to recognize these as enzymes that digest proteins. You should be able to recognize that. You should understand why there are so many of them. Why do we have so many different enzymes breaking down proteins? What proteins are broken down into? What happens to those things? And just the general process of the fact that you have to have this kind of stepwise, this kind of sequence-wise digestion of proteins to really fully break them down. Okay, lipids are not water-soluble. These are highly variable structures. You have triglycerides composed of a glycerol and 3 fatty acids. There are enzymes required to break bonds between those. Cholesterol does not need to be broken down for absorption. So it's a difference. So it's still a lipid, but does not need to be broken down. Lipid digestion begins in the stomach, but it's lingual lipase, a component of saliva, that starts it. That will be activated when it reaches the stomach, that low pH. You also have gastric lipase that is produced by chief cells. Together they digest 30% of triglycerides to diglycerides and fatty acid. Neither requires participation of bile salts. So at this point we're digesting lipids, lingual lipase and gastric lipase, not requiring bile salts. Pancreatic lipase is produced by the pancreas, digests triglycerides into monoglycerides and 2 fatty acids, requires separation of large lipid droplets into smaller droplets. So this does require bile salts to activate emulsification, or to emulsify the fats. I was trying to think of a way to use natural emulsification. So just for your refresher, you have your fatty acid tails, right? So when we talk about a glycerol molecule with a fatty acid tail, or a glycerol molecule with a fatty acid tail, that's what we're talking about breaking up. Okay, emulsification occurs by the action of bile salts. Bile salts are amphipathic molecules with a polar head and a nonpolar tail, similar to the plasma membrane. The nonpolar tails line up around the fat droplet, with heads towards the aqueous fluid, and create what's called a mycele. So you have the nonpolar hydrophobic tails that point inward, surrounding the fat droplet, which is also going to be hydrophobic, and then these hydrophilic heads on the outside surrounding it. That creates this thing called a mycele that allows for greater access of pancreatic lipase to the triglyceride, because it's isolating it. It kind of takes, instead of having this big kind of globule that it has to work with, it takes off just a little piece of it, and now that it has a little piece, that pancreatic lipase can go right in there and act right on it. The salts are recovered by active transport in the last portion of the ileum. So lipid absorption is a little bit different. Lipids are transported to simple columnar epithelial lining by the myceles. the lipids enter, and the bile salts are reused in saving lumen. So essentially, you kind of think about like, okay, you have this little lipid that's in a mycele, kind of surrounded by these bile salts. That's kind of what a mycele is, right? And so it kind of goes up and it approaches the epithelial cell, and the the mycele kind of opens and expands and kind of empties the lipid into it. Kind of it will basically. I don't want to say that it binds with the plasma membrane, but it basically creates a seal with the plasma membrane of the cell, so the lipid can be released directly into the epithelial cell and not float into the lumen. In the epithelial cells, so in the micelle it's been broken down into a monoglyceride. In the epithelial cells, the triglycerides become reformed with cholesterol and other lipids wrapped with protein. They form chylomicrons that are released by exocytosis. Those will then enter lacteals, lymphatic capillaries, the small intestine, and into the blood and deliver lipids to liver and other tissues. So you have a triglyceride that gets surrounded by bile salts and emulsified into monoglycerides. That is then called a mycele, right? When you have a lipid surrounded by your bile salts, you have your mycele. Your mycele transports those monoglycerides to the epithelial cell where it enters. Once it's inside of the epithelial cell, these triglycerides are remade. With cholesterol and the other triglycerides, they get wrapped around in proteins called chylomicrons that can then be released. So here you go. You have the digestion of the lipids, with bile salts, creating this mycele right here. You have pancreatic lipase that's going to break those down from triglycerides into a monoglyceride and free fatty acids. Here you have the mycele being transported to the epithelial cell. That is going to, again, the mycele salt. The salts will shed off. The triglyceride gets reformed within the actual epithelial cell. That gets packaged around proteins and forms chylomicrons. Those chylomicrons are what are absorbed in the lacteal. So if you were to say that triglycerides are absorbed directly into lacteals, depending on how you want to talk about this, you kind of have to mention that it's not just a free triglyceride molecule that's kind of floating around and it gets absorbed in the lacteal. It's a chylomicron. It is this lipid that is surrounded by a protein shell. Because remember, even though here they're in the lacteal, they're in a lipid-soluble environment. Once it gets returned to the bloodstream, it's in a water-soluble environment, and so the fat is going to need a protein carrier. All right, nucleic acid digestion. Nucleic acids are polymers of nucleotides. We have DNA and RNA. They have three basic components: your sugar, your phosphate group, and a nitrogenous base. Four different nitrogenous bases, if you remember. The nucleic acid breakdown in the small intestine is done by deoxyribonuclease and ribonuclease. I'll let you decide which one goes with which type. The nucleases are released by the pancreas to break the phosphodiester bond between the nucleotides. You then have brush border enzymes, your phosphatase and your nucleosidase, that breaks the bonds holding the phosphate and the bonds between the sugar and the nitrogenous base. The components get absorbed across the epithelium of the small intestine as individual pieces. So here you have your DNA. You can see your phosphate group, nitrogenous sugar, and your nitrogenous base. The nitrogenous base is kind of lined up in the middle, and you'll have different enzymes that are going to break all three of these off. Right, water, electrolyte, and vitamin absorption. The small intestine is the location of most water, electrolyte, and vitamin absorption from the diet. The small intestine absorbs almost all ingested water, about 8 out of 9 liters. The large intestine absorbs some, and the rest gets passed in feces across the epithelia into blood vessels. Electrolytes. The small intestine absorbs almost all electrolytes. Most of it is unregulated depending on your diet. So unregulated means that you're just going to absorb all of it, unless you have a whole lot, in which case you won't absorb as many electrolytes. If that is a severe imbalance, then you won't absorb as much water, because again, if we think about hypertonic, hypotonic solutions, and if you're not absorbing as much water, you're going to have diarrhea, which will limit your overall nutrient absorption. chapter 25 is like one of the most important ones we do. Iron has controlled absorption. Hepcidin is a hormone released from the liver, inhibits iron absorption. If those levels get low, hepcidin levels are decreased. Vitamins, you have fat and water soluble. You should know the difference. Fat, A, D, E, and K. Water are B and C. When the fat are absorbed in the lacteals, B and C absorbed through diffusion and active transport. B12, because it's so large, so it's absorbed by receptor-mediated endocytosis, requiring that intrinsic factor from parietal cells in the stomach. Do you want to say anything else here? No. Saliva contains the digestive enzyme blank, which breaks down starch into blank. What is going to break down starch? Amylase into maltose. Very good. If you remember, we're talking about starches. All of these are enzymes. All these enzymes digest proteins, except that should be pretty obvious. No, let's see the slide.